this lunch hour or whatever time period it happens to be for you for our Primary Care Masterclass in Sport and Exercise Medicine and Musculoskeletal Health. My name is Dr. Jane Thornton. I'm a primary care sports medicine physician based in London, Ontario, Canada. And it is my privilege to have Dr. Martin Schwellnus join us today for the masterclass and speak on how to advise patients with respiratory illness on exercise and looking at acute respiratory infections. So before we begin, I just want to voice a land acknowledgement. That's a tradition that we do here in Canada, I know elsewhere around the world as well. So we acknowledge that this is sacred land upon which we are privileged to live and work. We recognize the deep connection and longstanding relationship between Indigenous peoples and the land of Southwestern Ontario and of London. We acknowledge the Anishinaabe, Haudenosaunee, and Lenapehoik and Chinantan nations whose traditional lands were gathered upon here today. And we're deeply grateful to have the opportunity to be in this place. For housekeeping items, just a couple of them. We've turned off the chat and we'll be using the Q&A today. The session is being recorded and the introduction will be followed by about a 40-minute presentation from Professor Schwellnus and then a 15-minute period of Q&A roughly. And the masterclass is also co-developed with input from our scientific planning committee. So thanks to Dr. Eric Wong and Dr. Sadia Jen. And now I have the distinct pleasure of introducing our speaker today. Very honored to have Professor Martin Schwellnus join us, and he's the director of the Institute for Sport, Exercise Medicine, and Lifestyle Research at the University of Pretoria. He's a director of the International Olympic Committee Research Center in South Africa and a longstanding member of the IOC Medical Commission. He's also a specialist sports and exercise medicine physician who regularly consults with athletes of all levels. And Professor Schwellnus has published more than 300 scientific journal articles and is interested in many areas of sport and exercise medicine, notably the health benefits of regular exercise and prescribing safe exercise to all populations to reduce the global burden of non-communicable disease, the prevention and management of injuries in active individuals, and the protection of the health of the athlete. So thank you so much. And we are very honored to have you join us. And I will turn the microphone over to you. Thank you.
Thank you very much, and welcome to all of you. It's lunchtime for you. It's about 6 p.m. for me. I want to first just thank very much the organizers, Jane and the team, for the invitation to do this evening for me, afternoon for you. It is indeed my privilege to be able to share some ideas about exercise and exercise prescription and exercise advice to patients with the most common medical condition that face probably most of the population, but also athletes and active individuals, which is acute respiratory infections. I do have a few slides that I just want to put up as disclosures in terms of financial support. This is just a slide for acknowledging and disclosing financial support for this particular program. And particularly, there's some listed conflict of interest that I was given from Jane and Eric Wong. Also, throughout the presentation, the idea and certainly my desire is to have any potential bias managed by ensuring that anything I present, data and other recommendations, are in a fair and balanced way. Just to disclose my own financial support, apologies. The financial support for myself, I'm a full-time salaried employee by the University of Pretoria in South Africa. There is an honorarium for preparing and delivering this lecture. I am a consultant sport and exercise medicine practitioner in a part-time capacity. I do research and teaching for the majority of my time. But when I do see patients, I do get paid a consulting fee for the services that I deliver to patients. In terms of research grants and other grants, I do receive a grant, an annual grant, as part of a team, being the director of the IOC Research Centre of South Africa. And I am the recipient of several other research grants. The ones I've listed here do pertain to support we've received to do some of the research that I will present today, although there's no product or specific entity involved. So these are just general research grants. So from our Medical Research Council, the university, and the IOC. So let's jump straight into the topic. And I put this slide up and put right up at the center, a well-known icon that we all know, which is the SARS-CoV-2 virus, or a depiction of the SARS-CoV-2 virus. Maybe at the outset, I'd like to say that my interest in this comes actually a fairly long way in terms of understanding the effects of acute respiratory infection on exercising individuals, and how exercising individuals perhaps are either protected or maybe at higher risk for infections. But what was really intriguing was over the last obvious 3 years, particularly in 2020 and 2021, the height of the COVID-19 pandemic, to see the absolutely exponential explosion almost in terms of information that has become available to understand the interaction of exercise and infections. And so, strangely enough, there were obviously many, many negative things about SARS-CoV-2 and COVID-19 pandemic, but on the positive side, it really, really has increased our understanding of the interaction, what we're discussing this afternoon, which is exercise and respiratory tract infection. So I'm going to draw a fair amount on the data that have been specifically published on one virus, but then I will mention some aspects of other viruses as we go along. So the brief was advice to patients, and kind of being very practical. You'll have a variety of different settings, maybe in the situation that you may be working as a clinician, and encounter, and these are just 6 kind of areas where you may have to give advice to an individual sitting in front of you in a consultation, or a group of people like a team, about the interaction between exercise, physical activity, and infection. And so these are the 6 things I want to discuss very briefly, each of them this afternoon. The first one is the interaction between regular exercise, or on the one hand, or an acute exercise bout, on the immune system. The second one is whether regular exercise actually either protects or maybe puts an individual at risk for increased risk again for infection. The third point would be about vaccination, and does exercise play any role in advice that we give about vaccination? What about exercise as a predictor of more severe infections when you do get them, or an athlete gets them? And then a key one, which probably most of you have grappled with, and certainly I've grappled with, and that is how to transition between having a recent acute infection back into training in the first instance, and then returning to full performance, which is a continuum of the so-called safe return to sport. And then we knew about this in other viruses like Epstein-Barr virus, but certainly, again, COVID has put the spotlight on the issue of prolonged symptomatology in terms of certain individuals after an infection, and what is the role of exercise. So these are the 6 areas I want to cover, and hopefully you'll end up with some practical advice to patients in these 6 areas, and we'll present that in a summary as primary care takeaways, perhaps also discuss some barriers to practice change. So let's delve into the very first one. This is a huge area, and I don't claim personally to be an expert on all aspects of immune function, immunology, and the response of an individual either to an acute bout of exercise or effects of prolonged training. So I'd like to direct you, and hopefully these slides will be available to you, to 3, I would say, fairly recent, 1 very recent, and 2 fairly recent reviews that deal with physical exercise, immune response, and so forth. And I'm going to ask you to go through those if you really are interested. But what I will do is maybe give you a summary just on, as I see it, the gist of it all. So let's deal with 2 scenarios. What is an acute single bout of exercise, a training session or perhaps a match, do in terms of the immune function? And this slide is adapted from one of the recent publications by David Neiman, and David is probably the doyen of exercise immunology and understanding this. On the left-hand side of the slide, you'll see a graph which is on the sort of horizontal axis is whether there's a negative effect, a degree and duration of change is negative. On the left-hand side, minus the 1, 3, and 5, and on the right-hand side, positive. In other words, a beneficial effect. So it's a beneficial effect and a negative effect. And on the left-hand side, you'll see a variety of responses, and some of the abbreviations are in the slide below. But essentially, if you really want to sort of summarize it all, it's about effects of either a prolonged high-intensity exercise, like a marathon race, and a lower intensity walking bout, which is in light blue. And then looking at 3 aspects: adaptive immunity, innate immunity, and then just a general inflammatory response. And you can see that on the balance of it all, high-intensity exercise, a marathon race, has potentially negative effects on adaptive and innate immunity, whereas walking has a more likely positive effect on all aspects, mostly of the exercise. Both cause an inflammatory response, and the inflammatory response is significantly higher in the marathon race. So if you don't understand pictures and you like tables, then on the right-hand side of the bottom, I've summarized it really for you. If you wanted to look at what are the effects of an acute session of exercise, an acute load on adaptive, innate, and inflammatory response, and if it's either low to moderate intensity walking against a marathon race. And you can see from the slide that certainly when you measure these immune parameters, then prolonged high-intensity exercise lasting greater than 2 hours or so has potentially got some negative effects on various aspects of immune function. And on the other hand, a shorter but low to moderate intensity exercise has more likely got some beneficial effects on the immune response. But that's great for the acute bout. What about regular exercise training? And again, this is just a summary of what regular exercise training does. And again, on the left-hand side in that box, there are a variety of different immune functions and parameters that have been measured. And the summary is really that there are multiple benefits to the immune system from regular training. So this is the outcome measures here are the inflammatory responses and a variety of the immune parameters. The question really is, does this translate to more clinical outcome measures? In other words, things that we can measure as a clinician. And the issue here is, does regular exercise really protect against the development of an infection? In other words, it's not really now about the immune response, but whether or not somebody has and develops an infection. And again, I'm drawing on data, certainly initially from David Neiman, and there are 2 graphs here. The one outcome variable is measurements of fitness, and the other outcome measurable is exercise days. And really what I want to point out is that there are differences in terms of low fitness, for example, on the left-hand side, is associated with a higher risk of more number of days being ill over, say, a 3-month period from a respiratory tract illness. And these are not confirmed infections, they are symptoms. But nevertheless, there's almost a doubling of the risk of more days with respiratory tract symptoms in the low fitness group. And also in those that don't do any training regularly, like exercise days low, very similar kind of outcome. So both fitness and exercise days. So these are data that have been around for a while and have prompted us to advise individuals that regular exercise training actually protects them against an infection. Or, excuse me, not an infection, but symptoms of an infection. So that's sort of the summary very briefly prior to the COVID pandemic. But in the last few years, there are an enormous amount of studies that have been done looking at this one particular virus, SARS-CoV-2 infection. And this is a summary of a very large systematic review of over 1.8 million adults. And essentially, and again, I've given you the reference, it's a fairly recent one from less than a year ago, that shows that and individuals who participate in regular physical activity had about an 11% lower risk of developing SARS-CoV-2 infection. And so these are very compelling data to support the concept that regular activity has a beneficial effect and reduces the risk of infection. And you may not know this, but I mean, this has also been shown for other infections. And this is a study, and I've just also put it in here as one of the sort of landmark studies. It's again a systematic review and a meta-analysis, and it looked at 10 prospective studies involving over 1 million participants, and the outcome variable here was incident pneumonia. And again, compared to the least physically active, the most physically active group had an 18% reduction in the risk for incident pneumonia. So we've got two really, really large studies, systematic reviews with analysis of a very large number of participants, both showing that for different outcomes, incident pneumonia and SARS-CoV-2 infection, being regularly physically active is associated with a beneficial effect, a reduction in risk for infections. And so that is probably the bottom line of advice to anybody sitting in front of you about there are many reasons to be active, but one of the reasons to be active is also your risk for infections is lower. And the question, and we haven't got that very strongly correlated, but probably there's a good argument that that is related to the beneficial effects of regular physical activity on the immune system as the possible mechanism for this, which I showed in the first couple of slides. The issue about the risk and just using physical activity is one aspect, and it's a little bit more complicated. And I want to direct you to read up about the risk factors associated with infections by looking at the systematic review that our IOC consensus group and a subgroup of this led by my colleague Wayne Derman published a systematic review on the risk factors associated with acute respiratory infections. And this was in athletes, so this is not in the general population. And I just really want to put this up, the bullet points there summarize the outcomes of the review by highlighting the number of different risk factors, and training, which is what we discussed right up to now, is one variable. But there are other variables, including metabolic parameters such as vitamin D deficiency, risk during travel, certain sports, and obviously a seasonal difference, and competition. Competition may be related to many things, but also competition stress. So I just want to make the point that when somebody asks the question, what are my risks of an infection, then low physical activity would be one. But then there are other factors as well. Obviously, it's a bit more complicated. So in summary, the data that I've shown you has been for many, many years, and still probably is quite a popular way of looking at it, is the so-called J-shaped curve. So on the left-hand side, you would have on the vertical axis respiratory infection risk, and then on the horizontal axis, your exercise workload. And what I really have shown you is that regular training would result in a significant reduction in risk. But the issue here is whether or not there's a kind of a sting in the tail. In other words, does heavy exertion or high load result in a greater risk? And again, that comes back to that very first slide that I showed you about the marathon versus the walking, and perhaps immune suppression when you do prolonged high intensity exercise actually results in a higher risk. And that's the reason for the so-called J-shaped curve. And I guess the issue here is more always better. And we probably can conclude at this point that no, that's not the case. More is not always better. It's very individualized. There are many other factors. And one of the things that we as a group, when we published and did the initial research for the IOC consensus on training load and illness, we constructed that right-hand side graph where there is a difference whether you are a recreational sub-elite athlete, where you're more likely to respond with the high training loads being detrimental, compared to elite athletes where the high training loads, they've actually been able to adapt to them, and maybe that risk is not necessarily higher, the so-called J or S-shaped curve. So this gives you an idea about the relationship now of the excessive amount of training. The whole issue is more better. So generally, with most people sitting in front of you, you would argue that more is not better. But in elite athletes who are used to training a lot and probably been self-selected in some way, more training is not necessarily associated with the same higher risk. All right, so that was the exercise in immune system and kind of advice to give to people regarding whether your immune system effects may be protecting or not protecting you against infection, and whether more is better or not. I'd like to move on to the third part of it and just talk a little bit about another aspect. So maybe a team that you are looking after needs to be vaccinated because they need to travel somewhere, or it's simply just a normal public health policy to vaccinate, and there's a question about exercising regularly and whether that does or does not affect vaccine efficacy. So at the time that the SARS-CoV-2 vaccines have been developed, James Hull, myself, and Davids and Anshaw wrote a piece. We kind of had a look at the data, and we published that sort of in the height of the pandemic. And what we concluded from the very, very limited data at the time is that there is possibly a benefit from regular physical training, and it may enhance the vaccine response. It's likely not to reduce vaccine efficacy, and it could in fact improve it. But we did conclude that we need more studies. The issue is, in other words, for example, in regular exercises, is the vaccine more efficacious or not? And also, should you exercise sort of the morning before you have your vaccine? And those were the questions that were raised. So again, the benefits, if there were any from the pandemic, was that we were able to start looking at the relationship between regular physical activity and effects of the efficacy or effectiveness of vaccines. And here I would like to pay tribute to my colleague John Patricius from Wits University, just around the corner from myself, and other South African investigators, and including a very large health insurer that has a very large population of people that they monitor their physical activity. And they were able to publish a paper, and if you're interested in this, please go and read it, published in BJSM, looking at a population of 196 participant tests, and then looking at a subgroup of low physical activity, moderate or high physical activity, and then measuring vaccine effectiveness, and really showed that regular physical activity, in other words, the high group, the moderate versus the low group, the vaccine efficacy was significantly better. And so the conclusion was that regular exercise is a simple, cost-effective way of enhancing vaccine effectiveness, which is a new concept, and certainly, again, makes another point about the benefits of regular physical activity on your immune response, and in this case, your immune response to a vaccine, and would support the data that I've showed you in terms of the risk of infection being reduced also in your regular physical activity group. I'd like to move on to the next part of it, and again, I'm still on the issue of what does regular exercise do in terms of its benefits or not benefits on infection. In this instance, it's the outcome variable is if you do get an infection, are you more likely to have a more severe or less severe or no effect if you are either active or physically active or less physically active. And the second outcome is complications, usually measured as a hospital stay or intensive care, and even death. And again, the data from the COVID-19 pandemic was helpful in this regard. And I'd like to pay tribute here to Bob Salas from the Kaiser Permanente group in California. And again, that's a group of, they're a group that have been very active in promoting exercise as medicine. And Bob studied 48,000 adult patients and looking at physical inactivity and whether it or not it's associated with a more severe outcomes. And these are the main results here. They looked at 3 groups of individuals, those that were consistently active. These are the green bars in this graph, the inconsistently active orange bars, and then, if you like, the highest risk, just the ones that are consistently inactive. And the outcome variables here are those 3 graphs or figures that I've got here, which is the hospitalization, intensive care admission, and then death. So these data are quite clear that there's about a 2 times higher risk of, irrespective of the outcome variable you're looking at, in the inactive versus the consistently active group. And then I also, maybe the limitation of this, that these are self-reported data. And then again, coming back to the South African group, in this case, John and his colleagues worked with Jane, actually. Jane, you were part of this. And again, analyzed the outcomes from the database from this health insurer, Discovery, and again in 65,000 plus adults. And again, physical activity outcome variables, but these were now measured, and they were categorized as low, moderate, or high. And on the right-hand side, the orange block has the moderate versus low outcome variables, and then in the green, the high physical activity versus the low. And really, the outcome variables were hospitalization, intensive care, requiring ventilation, that's a complication, and then obviously death. And really, the interesting thing about this is just the dose response effect, that compared to moderate, high physical activity had almost a double reduction in all the complications and also in death, reducing the risk of dying from 21%, already a decrease in 21% versus the low physical activity group, but down to 42%. Really, again, compelling evidence about the benefits of exercise, in this case, not only in your risk of infection, but developing a more severe infection. And obviously also your mortality. And then to round it all off, again, there's a study that's a meta-analysis and a systematic review, and looking at the outcomes of regular physical activity in terms of hospitalization, severe death, and mortality. And again, the greatest benefit is that first, on the right-hand side, you can see the biggest drop in the risk is when individuals engage in about 500 minutes of exercise per week. And again, what is interesting to me is, although the solid bar, which is the main estimate, seems to have some effect in that at very high minutes per week, exceeding 1 or even 1,500, not all individuals respond positively, and there is perhaps a slightly, if you like, a sting in the tail in some individuals. So very high training loads, very high exercise loads, similar to what I've shown you before. Again, the issue of more is not necessarily better for everyone. But be that as it may, the compelling evidence is that exercising regularly, greater than 500 minutes per week, protects you from severe infections and complications. And I've shown you really, really good data. But most of these are from the SARS-CoV-2 virus and COVID pandemic research. The same study I showed you before on incident pneumonia also showed a significant reduction in the most versus the least physically active in terms of pneumonia-related mortality. So this is perhaps one study that supports that what we see with the COVID-19 pandemic is not necessarily only with SARS-CoV-2, but there are other pathogens, in this instant causing pneumonia, that show the same effect. So you can kind of safely conclude from all of this that regular exercise protects you against severe infection and also your chances of dying. And maybe if you do excessive amount of exercise, there may be in some individuals a higher risk, in other words, a sting in the tail. All right, so I'm going to, we've already done about half an hour. The last little bit, I've got two more things I want to briefly discuss. And this is about the advice on exercise to your patient who has an infection and they wish to return to training, in other words, during the recovery from an infection. And this has been a particular interest of mine, mainly because as a sports medicine specialist, I see athletes, and this is one of the most common clinical decisions to be made. And I would like to point you to the consensus statement that we published last year related to this. And I'd like to pay tribute to all the co-authors that were part of this group and the wider group of about 40 other people who contributed all very significantly to make these publications possible. But essentially, the take-home messages from this is that the simplified clinical decision on just using the so-called neck check and having a kind of a binary response, neck check is you pass the neck check yes or no, is probably too simplistic, and with new data, we can refine that. The question that we were trying to answer is, what are the best predictors of returning back to sport? And so the one concept that I really would like to state right at the outset is that it also return to sport decision is not you can return to sport or you can't. The return to sport decision is really a process, not a single decision, and certainly not a single time point. And broadly speaking, we would suggest that it starts with a decision on first when an athlete can return to training. And I'll come back to this in a moment with a stepwise approach, but with the end result being the athlete is back to the level of full performance, the so-called return to training endpoint and the return to full performance endpoint. And actually, there are multiple clinical decision steps that are taken on the way, and we'll go through that in a moment. So one of the things that we were interested in, mainly because, again, the SARS-CoV-2 infection problem in athletes during the pandemic enabled us to study this. And we were looking at what are the predictors, clinical predictors and other predictors that would give you an idea who is more likely to return to training earlier or later. And we studied a population of athletes with SARS-CoV-2 infection. I would like to pay tribute to Dr. Carolette Snyders, who's a PhD student from us. She's now graduated. And she did a lot of this work during the COVID pandemic and published this paper in MedSci Sport and Exercise, where we showed that symptom number and not training in the sort of week to 10 days before, or reduction in pre-infection training, were the two main predictors that's indicated who would take longer to return to training. And the summary of this is in the orange block at the bottom. And I really want to point your attention or draw your attention to the predictor of return to training in this study. Best predictor, in fact, was just the total number of symptoms during the acute phase of the infection. And that was certainly something new. So in other words, instead of neck check, let the athlete tick off all the symptoms and count the number of symptoms. And that may be the most important predictor about who will go back to sport sooner, training sooner, and who will go back not so soon. So this is the slide that looks at a new parameter that hasn't been reported before. And I'm going to ask you not to share this on social media, because this paper is currently in review. And it now looked at not when an athlete goes back to training, but actually goes back to full performance. And again, this is in a cohort of athletes with SARS-CoV-2 infection. And the main findings are that prolonged return to full performance in a multivariate model was also strongly associated with total number of symptoms. But on the right-hand side, particularly with so-called whole body symptoms or systemic symptoms, that was a stronger correlation to returning to full performance earlier or later. And then, but also in chest, neck, and then nose, throat symptoms. On the left-hand side is a survival curve, if you like. This is the probability of not returning to full performance. So the steeper the slope, the greater the number of athletes returned to full performance. And what I want to show you just is that there are three graphs, and I apologize, the color is probably not that great on the screen, but if you take athletes with, say, five symptoms or less, then they return to full performance very significantly quicker or earlier than athletes with either 8 or greater than 10, 11 symptoms. So there's almost a dose response, greater number of symptoms, later to return to full performance. So the same relationship that Caroline showed for returning to training, which is the first time point, also holds for full performance for these athletes with SARS-CoV-2 infection. And then another PhD student of mine has just had a paper accepted in the Journal of Athletic Training. It's online. You can go look at it. It's free. Where we studied the actual exercise response during a submaximal exercise done 10 to 14 days after the onset of symptoms in patients with SARS-CoV-2 infection. And the parameter that was particularly of interest was the rating of perceived exertion. We studied other parameters as well. We've also published those data on heart rate and blood pressure. And we showed previously that they have a higher heart rate after infection, and it takes about 30 days to return back to normal. But this study was about the rating of perceived exertion. How do they feel during the submaximal exercise test? And what were the predictors of a higher rating of perceived exertion? And as it turns out, it's exactly the same as the return to training and return to full performance. Again, it's the total number of symptoms. And the graph on the right-hand side shows the difference between those with fewer symptoms, lower heart rate. This is at stage 5 of a modified Bruce protocol, against those with 8, and then the highest RPE was those with 10 or more symptoms. So again, symptoms were predictive of a higher RPE during submaximal exercise done 10 to 14 days after infection. So the kind of matrix of all of this is, we know, and the IOC consensus on severity of illness, also as with injuries, says the more training days or days lost is a parameter of the severity, or a definition of the severity of infection of an illness for an athlete. And so return to training, return to full performance, days to return to training and full performance are measures of severity. We think that the severity of certainly SARS-CoV-2 infections in athletes really can be fairly simplified by just counting the total number of symptoms, because we've now shown you the data that total number of symptoms or severity is related to return to training and return to full performance. And I've also shown you data that it's related to the rating of perceived exertion at the first training session. What I haven't shown you, and this is another paper that's in preparation for submission, and again, please don't sort of tweet this too much at the moment. We've also looked at the number of organs involved in the pathology, in other words, multi-organ involvement. And we've also shown, this is again Caroline Snyder's work for a PhD, show that the more organs involvement is related to the total number of symptoms. And again, that's the same severity. So we kind of think that at the moment, severity of certainly SARS-CoV-2 infection is associated with these various outcome variables. More total number of symptoms is predictive of how many organs are involved. It's also predictive of how you feel during exercise, and it's also predictive of when you can start training, and also predictive of when you can get back to full performance. So the clinical take-home message of all of this is that certainly for SARS-CoV-2, it appears that if you just look at the total number of symptoms and obviously more systemic symptoms, you get an idea as to how they will respond to exercise, how many organs they may have additionally involved, and probably from our point of view, for athletes most important, there may be longer getting back to training and then also longer to get back to full performance. You may say to yourself, well, that's clearly only for SARS-CoV-2, and of course you're 100% right. So I've only got this very preliminary data from some of the patients that we tested that didn't have a SARS-CoV-2 infection, but had an other infection. And we have 71 of those kind of athletes. And we have shown the same thing, actually. So there, in this case, the graph is a little bit better, I think. This is the return to training, return to play. The blue is a more rapid return to training. The red is intermediate, and the green is a delayed. And the green is if you've got more symptoms, in this case, so 12 symptoms. So very early days, but this relationship between total number of symptoms and return to training, I've shown you the data for athletes with SARS-CoV-2 infection, but these data, and they're very preliminary, may actually show that it holds for other infections. And I've got a PhD student at the moment who has recruited about 35 participants already with other infections, mostly other infections, and we're investigating this with confirmed infections in a large sample size at the moment. And it'll be interesting to see, maybe in 18 months' time or so, when the results are out, whether this holds. So in terms of return to sport decision-making, what I'd like to discuss is just the findings of our consensus. And essentially, I'm going to just direct you to that consensus. I've already spoken about the fact that it's a process, not a single decision. And probably there are kind of 4 steps or 4 decisions that need to be made. And for that, the IOC consensus developed tools to help you with that. And I'd urge you to go back to that consensus document. And essentially, step 1 would be to assess the severity of the illness. And my suggestion is probably mostly the symptoms. And then we've developed, and I'm not going to go through them in this talk, but pre-exercise checklists, both for use by the athlete themselves on their own or the coach, or a similar checklist with a few additional details to be used by a health professional to make a decision as to whether the individual can start with training. That's the step 2, return to training. Step 3 is an ongoing decision, and it really relates to using a post-exercise checklist, which is also in the document, to decide, can the training load increase? And it's an ongoing decision until they get to full performance. And the decision to let them go back to full performance then has to be taken into account by assessing multiple other factors, including an assessment of risk tolerance. So this is our current return to sport decision-making process, and it's a modification of the stepwise approach. This is just a very busy slide, and I just wanted to put the slide up so that you can remember, if you really want the details, go to the consensus statement. And on the right-hand side, I've summarized where these different steps fit in to the return to sport decision kind of algorithm. Finally, in the last minute or two, just advice on patients with prolonged symptoms. And again, there's a lot of debate at the moment on so-called post-COVID-19 conditions. We know that there are many names and very definitions of this, but essentially it looks as though it's a multi-systemic condition and really of ongoing severe symptoms that follow, in this case, SARS-CoV-2 infection, but we know it's also with other infections in the past it has been described. Seems to be quite common in the general population, more so in the more severe cases of those with admitted to a hospital. We also know that it's very complex and poorly understood, and particularly the pathophysiology and pathomechanisms are not. And there are multiple treatment modalities, none really have been proven. But the big question is about exercise. And really, this is just a slide to show you, it's a very good review if you'd like to read that from earlier this year, a couple of months ago, the main findings and mechanisms and recommendations. and talks about symptoms and the different types of pathologies that are associated with potentially those symptoms. Essentially, the purpose of this slide is your patient, your athlete, can present with many different types of symptoms and various combinations of symptoms. The pathophysiology is also not understood, and this is also a very nice summary of the kind of things we are interested in as potential mechanisms. Immune dysregulation, dysbiosis in your microbiome, autoimmunity is probably a big thing, microvascular clotting, and dysfunctional signaling in the nervous system, particularly the vagus nerve. And that may be very relevant to athletes presenting with prolonged, for example, a higher submaximal exercise heart rate. What is the advice on exercise? Well, the CDC guidelines are really that physical exercise might be indicated for patients, particularly with post-exertional malaise, and that it's almost best done on an individual patient basis. And it's got to be done as a gradual return because it may exacerbate symptomatology. In my practice, when I see these patients, I evaluate them. I try to work out which of these pathophysiological mechanisms are dominant, and probably in all of them, I would definitely do a trial of exercise, and gradual progression is the key, and individualizing the program is the key. So there are two studies that have shown some benefits. I'm not going to go through them, but essentially they are small sample sizes, only one really RCT I could find. But essentially exercise has beneficial effects, and that's why in my book it has to be a part of the treatment, at least as a trial of exercise and individualized. So let me summarize, and then we'll have some time for questions. Some takeaways, and I'm going to go through the 6 here. So immune function, I think we're quite clear on that. Single exercise greater than 2 hours may have detrimental effects. Otherwise, it is very beneficial in acute. And also, the second point, is it beneficial in the long term? Well, there's very strong evidence for that, I think. The only would be the sting in the tail in some individuals. If it's absolutely excessive, you may have that J-shaped relationship versus elite athletes with the S-shaped relationship. Vaccines and exercise. Regular exercise appears to enhance vaccine effectiveness and should be encouraged. Advice on exercise and more severe infection. I've shown you the data. Really, you'll have a likely reduction in risk if you exercise about 500 minutes per week. And then safe return to sport. Just a few general points. It's not a single decision. It's a series of decisions. It's not a single point. We suggest a stepwise approach, and we've given you some ideas of tools to use for that. And then exercise for prolonged symptoms after infections, complex, but generally beneficial, probably advocated to most patients, but follow a cautious approach and individualize it and monitor responses and adjust. Some barriers to change just that I have come across. One of the major ones is sporting culture, athlete, coaches, and management. And I've learned to really solve this by adopting a very shared decision-making process and to grow partnerships with the coaches and the management and so forth. Knowledge, there's a lot around in social media and other media, so use trusted sources. In terms of translation, use every opportunity for education, for example, on the benefits of activity that we spoke about, for general health, risk of infections, and also for vaccination. Resources, that's difficult, but we've tried to develop some tools in the IOC consensus that could even be used by the athlete and the coach to empower them to make good decisions. Develop tools for effective short communication, like elevator pitches about the benefits of exercise on immune system and infections. I think it's important to address, particularly after the SARS-CoV-2 pandemic, address psychological, emotional factors in trying to implement, for instance, an exercise prescription because of the fear that, I may have myocarditis and so forth. but also denial that I can just carry on exercising and there'd be no consequences. So be aware of those potential barriers to practice change. Thank you very much for your time, and I'd just like to draw your attention to this conference next year. I think all the information is kind of on the websites. Have a look at it, and if you can, try and plan to attend it. Thank you very, very much.
Thank you, Martin, so much. What an honor to be able to have you join us today, and what a fabulous presentation. I second the recommendation to apply to and to come to this conference in Monaco next year, as it is a fabulous one. I just, again, wanted to thank you, Martin. I think whenever I hear you speak, I'm so inspired by the tremendous contributions you've made to the field of sport and exercise medicine in total, but also the tremendous amount of work that's gone into all of your work on respiratory illness, and having seen all of these manuscripts come through and being published, and what a comprehensive overview for our physicians. So I know they're deeply grateful for that, and also any other healthcare providers who are joining us today. I know I refer to these recommendations often, and I just had a couple of questions to start off. What I would say to the audience, for those, we have about 8 or so minutes left of the presentation. Feel free to drop any questions into the Q&A, and then if you like anyone else's questions, you can kind of upvote them if you like them, and then we can kind of rank them in priority sequence. I certainly have a few, so I'm happy to start us off on that. And I guess the one thing first, Martin, is that I love that you address the above the neck check, because that's advice that we've heard for years, in terms of as long as you're okay, neck and above, go back and return to sport, and how it's more so the total number of symptoms. And it may not just be COVID, but then also other infections or illnesses. I'm just wondering if you, and this is kind of more of a practical question than anything, do you ever notice if athletes or coaches kind of minimize that total number of symptoms, or would you have any advice to kind of on a practical basis, getting a sense of if they feel ready to play or ready to participate in sport, if you have any kind of, do you personally give any guidance and say, if you don't follow these recommendations, X, Y, Z, or Z can occur, or how do you approach that particular topic?
Yeah, thanks. So it's a very, very good question. It's related to whether athletes and coaches actually even indeed report any symptoms whatsoever. So what I've learned through this is that when they report fewer symptoms and less symptoms that are either of a regional or systemic nature, we actually let them exercise. So so slowly the message comes across, actually, if I do have a runny nose, I can exercise. I'm not going to be told that I don't have to exercise. So to move away from the binary, yes, you've got symptoms, or you've got, you fail your neck check, to actually discussing and saying to them that some symptoms are okay, and to report, encourages them to report. The other issue is that my tolerance to getting them back to the first training session is lower. I would actually, I would say to them, okay, you've got a number of symptoms, but you can actually do an exercise test, and if you do that and you find abnormalities, you can probably continue to do some training. And I think that's the big difference. The binary part of it, yes, no, neck check above and below. It's also exercise or no exercise. That's also not correct, I think. So what I've learned is that you can say, get back to training, and but let's see how you respond. And in some cases they respond quite quickly, and you can progress the training. It's the same kind of training advice we give to athletes with concussion and ACL. It's the same approach, really. I don't know if that answers the question, but
yeah, no, that's fantastic to hear. And so, and interestingly too, I think with some of the elite athletes, this is more from an athlete perspective, returning to sport and asking the questions around, okay, well, maybe I've got a lot of symptoms and aerobic or intense activity is maybe not for me just yet, but what about resistance training and things like that? And I wonder if you also get questions not only about the safety of resistance training early on the recovery, return to sport aspect, but also any benefits when we're used to hearing about aerobic guidelines and things like that, but I wonder if you've come across anything about resistance training as a kind of
thanks very much. Thanks very much for that question. And that so one of the things that we've also measured, and we're just busy analyzing it, is not just the sort of endurance response, or the response to endurance training or an exercise test, but things like muscle strength, muscle endurance, neuromuscular control, balance tests. And I can just anecdotally say, if we look at the raw data, that infections also have a negative, or can also have a potential effect on that. So, but that seems to recover much quicker in some athletes. So really, again, I always want to give credit, if you like, to the COVID pandemic. We've really learned a lot about how the body responds to a pathogen that invades the body and has a variable effect, and how that affects various systems. And I think we've understudied completely the musculoskeletal muscles, effect on muscle and neuromuscular control. And we're learning about that. And so the decision to allow weight training, I would almost at the moment just say it's the same. We'll allow you to go back to some weight training, but not at the same level prior to the infection. Let's see how you go and how you feel. You may find that your muscle strength is not exactly the same. Your ability to do a bench press or whatever exercise you normally do, or your plank time when you do a prone test, is going to be slightly different. But they seem to recover quickly. So for those people out there, I mean, I think this is, we just need more and a better understanding of how these infections not only affect cardiorespiratory response, as you rightly said, but also muscle strength and neuromuscular control, and therefore these training programs. Yeah.
That's great. I know I know we only have a couple minutes left, but I know for our family medicine colleagues who have essentially ranked this as one of the most important topics that they wanted to hear about from our masterclass, most would get quite a high proportion of their patients as being sedentary or inactive. And I'm just wondering, because I can hear the patients saying, well, what are the minimum? And I know you touched on this a little bit, but in the sense of if you're talking to a sedentary patient or someone who's fairly inactive, just about the recommendations, more probably from a preventative aspect, more so than the treatment side of things. Do you have any thoughts on how you might approach that conversation with those patients to say, here are the benefits of getting active, or how that might be framed?
Yeah, it's also a very good question. I mean, I do that a lot, and and because I do it a lot, even when we socially engage with people, and my wife is now telling me all the patients that she's, all her friends that she's encouraged. And really, my advice is always, whatever you do at the moment, if it's very little or nothing, just start doing something. And so my advice would be, if you haven't got any musculoskeletal limitations, just start walking. Walk for 10 minutes every second day, and then 10 minutes a day. And then the other bit of advice I say is, when you have a flight of stairs, actually go up at least one level to start off with, and maybe later 2 or 3. So the issue is, I mean, I can go back to the graph there of the benefits, but the steep decline is with the small change at the beginning. And so I don't say to patients, you have to do 150 minutes of moderate to high intensity per week. That's too daunting. I just say walk for 10 minutes on the flat, go with a friend, have a chat, and just start doing that regularly. And then you can increase that, because the benefits, the health benefits, not just on infections, but as you know, the other health benefits, the steep decline is from going to nothing to something. I don't know if that helps. And I try to frame that in a way that the patient then doesn't feel daunted, and rather inspired to actually just make a very small change that can have a much bigger benefit.
Excellent. Thank you so much. And it's perfect timing. So we've got 1 minute left, and to respect everyone's time, for those that would like to look at the chat, there's also, Kristen has put the link out for the evaluation survey, and also her email address if anyone has any follow-up questions or comments. And so essentially, if you could please fill out the evaluation for your CME. We want to thank you again so much, Martin. We're so thrilled to have you here today. And thank you so much for that comprehensive overview of respiratory health for our patients. And we hope you can join us again at another time as well. So thanks everyone for joining today, and looking forward to, we have another masterclass next week. So please feel free to join in on that as well. And we will see you all soon. Thank you.
Thank you very much, everyone. Thanks, Jane.
Okay, thanks.